So now let's continue talking about the common genetic diseases, in this case monogenic Mendelian disorders, and we just finished talking about the autosomal dominant disorders. Now we'll talk about autosomal recessive disorders. To summarize, the majority of the Mendelian disorders are actually autosomal recessive, and only homozygotes are infected. The heterozygotes, the parents, are only carriers. So looking at a Punnett square again, you'd see there are 25%. 25% of the descendants would be affected. And if the mutant gene occurs with low frequency, there is a high probability in consanguineous marriages, and that means where relatives are paired. And the onset of symptoms is often in childhood, before puberty, and there's also frequently an enzymatic defect, and there is testing of parents and amnion cells, so for example in an amniocentesis. And so let's look at an example. We're going to talk about cystic fibrosis, PKU, Galactosemia, glycogen storage diseases, lysosomal storage diseases, Gaucher disease, and even Tay Sachs, and mucopolysaccharidosis. So, starting with cystic fibrosis, this is 1 in every 2,000 live births. It is the most common lethal genetic disease in the white population. In this case, there is a defect in the transport of chloride ions across the epithelial cells, the epithelia, and which results in an increased absorption of sodium ions and water to the blood. There is widespread defect in the exocrine glands and abnormal viscid mucus secretions, which results in the blockage of airways, pancreatic ducts, and biliary ducts. So we have very, very thick mucus. So with cystic fibrosis, you will have pancreatic abnormalities in 85% of the cases, which is a dilation of the ducts, atrophy of the exocrine part, and fibrosis. Then there would be pulmonary lesions, dilation of bronchioles, mucus retention, repeated inflammation, bronchiectasis, lung abscesses, emphysema, and atelectasis. That would be with 100% of the cases, and cor pulmonale chronicum. So we do also see a GIT, meconium ileus, in newborns, 25%, biliary cirrhosis, 2%, and as for the male genital tract, there would be sterility because of the obstruction of the vas deferens, epididymis, and the seminal vesicles. That would happen in 95% of the cases. And as for the clinical symptoms, there would be recurrent pulmonary infections, pancreatic insufficiency, malabsorption syndrome, large foul stool, and hypovitaminosis. That would be for A, D, E, K, and poor weight gain. In addition, there would be a high level of sodium in the sweat, so you would have very salty skin in children, and a mother could easily diagnose that. And there would be death usually in the third decade, before the third decade, due to respiratory failure. Very, very sad. Now let's discuss PKU. In PKU, phenylketonuria, there is an absence of the enzyme phenylalanine hydroxylase, PAH. Usually you would have phenylalanine resulting in tyrosine, because we need tyrosine, and this enzyme is needed. But in this case, that enzyme is absent, and there would be an increase in the plasmatic phenylalanine since birth, which raises the levels and it results in the impairment of brain development. So after 6 months, there would be severe mental retardation and an IQ of under 50. There's also decreased pigmentation of hair and skin and an absence of tyrosine. So it's important to have early screening tests and also to watch your diet. For mothers with PKU, there is an increased level in phenylalanine, and phenylalanine to transplacental transport. So you would have a child with severe mental defects, even though it is heterozygous. So for those, for mothers with PKU, the diet is really, really important. Now let's discuss galactosemia. There is a defect of galactose metabolism, of course, and then you would have lactose going to galactose and glucose. So there is a defect in the galactose to glucose defect and accumulation of galactose in the blood. So this results in problems with the liver, the eyes, and the brain. There is hepatomegaly, fatty change, fibrosis, cirrhosis, and with the lens you have opacification and even cataracts. You could even see cataracts in small children. With the brain there would be a loss of neurons, gliosis, and edema. And the brain has a limited space, so edema is of course very bad. And as for the symptoms from birth, you'd have vomiting, diarrhea, jaundice, hepatomegaly, and later there would be cataracts, mental retardation. So again, the diet is really, really important here. Moving on to glycogen storage diseases, or glycogenoses, there is deficiency of any one of the enzymes involved in the degradation or synthesis and of glycogen. So this depends on the type of defect, but there is tissue distribution problems, types of accumulated product, 12 forms of, there are 12 important forms. There's, for example, type 1, von Gerke disease, which is a hepatorenal type. Type 2, Pompe's disease, generalized type, liver, heart, skeletal muscle. And type 5, for example, McArdle syndrome, skeletal muscle only. And for the biopsy, you need to take a biopsy to find out. I'm a little bit confused about this one. I've got to look at the small glycogen storage disease. It's very difficult. How about lysosomal storage diseases? In this case, there is a defect of the lysosomal enzymes hydrolyzing various substances. We're talking about the sphingolipids and mucopolysaccharides and the storage of insoluble metabolites in the lysosomes. This is extremely rare. So the problem here with these sphingolipidoses is very, very frequent in the Ashkenazi Jews in their community. Others too. How about Gaucher's disease? This is a defect of the glucocerebrosidase, and there are 3 types: type 1, survival; type 2, lethal type; and 3, intermediate. There is an accumulation of glucocerebroside and glucose to ceramide and kerosene. There are Gaucher cells in the spleen, in the liver, and in the bone marrow. In the spleen, in the red pulp, in the liver, in the sinuses, and in the bone marrow. So what is Gaucher disease? It is a genetic disease in which a fatty substance accumulates in cells and certain organs. The disorder is characterized by bruising, fatigue, anemia, low blood platelets, and enlargement of the liver and spleen, and it is caused by hereditary deficiency of the enzyme glucocerebrosidase. And this enzyme affects the glucolipid glucocerebroside. And when the enzyme is defective, glucosylceramide accumulates, particularly in the white blood cells and most often macrophages. Glucosylceramide can collect in the spleen, liver, kidneys, lungs, brain, and bone marrow. Oh, I can't even pronounce that. Glucosylceramide. Wow. It's no good if you can't pronounce it. Okay, moving on to Niemann-Pick. If you're still watching this video, you deserve a gold medal. Niemann-Pick, defect of sphingomyelase, accumulation of cholesterol and sphingomyelin in the spleen, liver, BMLN, lungs, massive visceromegaly. CNS, central nervous system, you would find foamy cells, severe neurological deterioration, and death during the first 4 to 5 years. another very, very horrible disease. And then Tay Sachs. We've talked about Tay Sachs before. This is results in mental retardation, blindness, and there's a problem with the neurons and glial cells of the CNS. Let's talk finally about mucopolysaccharidoses. And mucopolysaccharides are synthesized in the connective tissue by fibroblasts, which is part of the ground substance. And there are several clinical variants, 1 to 7. There is involvement of the liver, spleen, heart, valves, coronary arteries, and blood vessels. And the symptoms, there are coarse facial features, clouding of the cornea, joint stiffness, mental retardation. It's also known as gargoylism, although that's not a very politically correct name. And there's usually death in childhood from cardiac complications, and the most frequent types would be Hurler syndrome and Hunter syndrome. And Hunter syndrome is X-linked.